Very good morning to all. So, I would like to welcome you all on this first and early morning session on angle closure disease. It's going to be a very interesting session with great panelists here. So, angle closure disease is something we find it difficult to start managing, either be it medical management, laser management, or surgical management. It is going to be a tough call to manage. So we'll have a great session on tips, hints, and hacks on how to manage angle closure. And at the outset, I would like to thank all my co-instructors for being here. And we'll have Dr. Indra Durai from Aravind Eye Hospital, Madurai, who will be introducing us about angle closure disease, the basic pathology and pathophysiology. Over to you, Doctor.
Okay. So good morning, everyone. In this talk, I'll be covering some of the latest developments in the diagnosis and management of angle closure glaucoma. So gonioscopy continues to be the gold standard for diagnosing the presence of angle closure. It provides useful information such as presence of synechiae, pigmentation, and plateau iris. However, this is a highly subjective procedure. Quantitative studies of the anterior segments such as the AIOCT and UBM provide objective measurements. AIOCT is a non-contact procedure which can visualize the entire anterior chamber and can provide parameters for detection of angle closure in a single scan. The recently developed deep learning based digital gonioscopy system, which uses the 3 swept source OCT, has been developed, which stimulates both static and dynamic gonioscopy and helps to detect narrow angles and presence of pus. UBM has the distinct advantage of imaging the posterior chamber and the ciliary body and can be used to identify certain conditions such as the plateau iris and the iris cyst. However, anterior segment imaging cannot be replaced by cannot replace gonioscopy and can be only serve as a useful adjunct. So in PACG patients with progressive GCC thinning on SD-OCT, the functional progression was detected much earlier than in patients with progressive RNFL thinning. OCT angiography shows that lower superficial vessel density was significantly associated with a faster visual field progression in PACG. One advantage of this technique is it can be used to monitor progression in patients with advanced glaucoma as it was less affected by floor effect. Choosing a program on standard perimetry is based on the disease severity and macular function. The patterns of visual field damage in chronic PACG is different from POAG. PACG has a more central advanced field defect. So recently the 24-2C protocol has been developed, which adds the 10 central points from the 10-2 grid to the standard 24-2 grid. This enables us to perform both the peripheral and the central visual field testing in the same sitting and can be used in both early and advanced cases of glaucoma. So the mainstay of treatment in angle closure disease is the laser peripheral iridotomy, which eliminates the relative pupillary block component of the angle closure process and is indicated in patients with angle closure suspect, acute angle closure glaucoma, and primary angle closure glaucoma. Considering the larger prevalence of PACS in our population, one question which commonly arises in our mind is, do we need to do a peripheral iridotomy in all patients with PACS? To answer this question, both the ZAP trial and the Analyst trial has showed that though eyes treated with peripheral iridotomy has shown a significant 50% reduction in the development of PAC or acute attack, the rate of progression was less than 1%, hence they do not recommend a PI in all cases of PACS. However, in certain conditions, like PI can be done, like in fellow eyes of acute primary angle closure, PACS, or patients with poor access. Iridoplasty is not that can be used in certain situations like acute PAC for rapidly lowering the intraocular pressure in patients with corneal edema or in patients with PAC or plateau iris syndrome who do not show an improvement after iridotomy. In PACG, however, ALP is less effective than when compared with prostaglandin analogs. SLT also has a limited role in PACG and shows a short-term reduction in intraocular pressure and has no additional benefit when compared with prostaglandin therapy. So micropulse lasers can be safe and effective as a temporary measure in reducing intraocular pressure in patients with refractory and advanced angle closure glaucoma with a good visual potential, where the risk of surgical intervention is very high. In medical management, prostaglandin analogs have been shown to be as effective as beta blockers in the management of chronic angle closure glaucoma. The surgical management depends upon the clinical presentation. In patients presenting with acute primary angle closure with cataract, early phacoemulsification has resulted in a better intraocular pressure control and the need for less number of glaucoma medications when compared to laser PI, and especially when it is performed within a week of resolution of acute attack. So in patients presenting with a clear lens in PAC or PACG with mild damage, clear lens phacoemulsification has shown to be superior to laser PI and is recommended as a primary intervention, especially in patients older than 50 years old. In patients with medically controlled angle closure glaucoma with coexisting cataract, phacoemulsification alone has been found to be more effective when compared with phacotrabeclectomy, as the latter had a higher rate of complications. Similarly, in patients with medically uncontrolled angle closure with coexisting cataract, phacotrabeclectomy was found to be superior to phacoemulsification in controlling the intraocular pressure, but it had a higher rate of complications. In patients with medically uncontrolled PACG without cataract, trabeclectomy was found to be more effective than phacoemulsification alone in controlling the intraocular pressure, but again had a higher rate of complications. So in patients with advanced PACG, uncontrolled intraocular pressure and cataract, primary trabeclectomy was the preferred choice. In patients with peripheral anterior synechiae and cataract and mild PACG, both phacoemulsification and phacogoniosynucleolysis has been found to show a significant reduction in the intraocular pressure, but there was no added benefit of phacogoniosynucleolysis over phaco in PACG. Combining cataract surgery with MIX can be safe and effective in early cases of PACG, but its role in advanced PACG remains unproven. Glaucoma drainage devices in PACG eyes can be done in certain individuals, especially with a sufficient deep anterior chamber angle, or in patients with pseudophakia with a shallow chamber where the tube can be placed in the ciliary sulcus. Thus, to conclude, the rate of bilateral blindness in angle closure glaucoma remains high. A thorough history and eye examination is important to differentiate between primary and secondary forms. It is important to utilize the various diagnostic and laser or surgical options at our disposal so as to optimally manage this condition, so as to minimize or reduce further vision loss. Thank you. I'd like to thank Dr. Madhavi and the organizers of AOC for this opportunity.
Thank you, ma'am, for setting the stage and giving a very elaborate introduction. Next, I'll be talking on gonioscopy and the role of imaging. Closure. So gonioscopy helps us to guide the diagnosis, but also helps us in formulating a treatment plan. Also, with the introduction of minimally invasive glaucoma surgery, its importance has grown multifold. So the question is, are we doing enough gonioscopies? So in the Chennai glaucoma study as well as the Andhra Pradesh eye disease study, we have seen that 2/3 of the angle closure glaucoma patients who were already on treatment, they were being treated as open angle glaucoma, either because gonioscopy has not been performed or inadequately performed. And in this study conducted in the US, only 45% of the patient had received gonioscopy following initial diagnosis of open angle glaucoma. So what hampers us from performing gonioscopy? This may be attributed to the limited training one receives during their residency. Also, it is a very time-consuming procedure. It is difficult both for the patient as well as the doctor. And the subjective nature of the procedure itself with multiple and confusing classification systems. So is Van Herring's grading enough? No, the sensitivity of Van Herring's grading was just 61.9%. So gonioscopy is a must. So the AIGS consensus and the World Glaucoma Association states that gonioscopy is recommended in every standard ophthalmic eye exam. Gonioscopy not only helps us to differentiate angle closure from open angle glaucoma, but also helps us to look at the various other pathologies in the angle, thereby helping us to reach a diagnosis. So why is gonioscopy important? Because angle closure disease is a disease which is more blinding than open angle glaucoma. And pre-op gonioscopy is very helpful, especially while planning minimally invasive glaucoma surgery. And note that a diagnosis of open angle glaucoma should not be performed unless a gonioscopy has been performed. So let's look at some pearls for a great gonioscopy. Always remember that gonioscopic examination, gonioscopic status of an eye is a dynamic. So we have to aim to get the best possible view with minimal distortion and try to identify the angle structures properly. And the point is make the patient comfortable. Not only the doctor, but the patient also should be comfortable to get a good gonioscopic view. And center the lens. Avoid distorting the cornea with corneal fold so that there will be distortion of the angle structures. Make sure the lens is properly centered. And use a short thin beam with minimal angulation so that you won't have much reflection and the chances of seeing the angle structures more distinctly is improved. Look for landmarks. Scleral spur is often one of the brightest white lines in the angle and it serves as a very important landmark. And after seeing all these structures, describe the angle in toto. See, look for the amount of pigmentation, presence or absence of synechiae, iris insertion, angulation, etc. And one should also know the gonioscopy lenses, the Goldman style lens and the Zeiss style lens. In the Goldman style lens, which is easy to start off as beginners, and it's also good for photos and laser procedures. But the problem with Goldman lens is that you cannot do indentation properly. While the Zeiss style lens, it is easy and convenient in a high volume setup, but it is difficult to master and it is greater for indentation. So the Zeiss style lens comes as Posner and Sussman, and you can see most of the angle without rotating the lens if you are using this lens. So the new one in the field is the Wolf G6 lens. It has 6 mirrors rather than 4 mirrors, and it helps us to provide a true panoramic 360-degree visualization and a complete view of the angle in toto. So the most important thing is practice regarding gonioscopy. Apart from gonioscopy, you can use an eye cam for visualizing the anterior chamber angle. Also, endoscopy can also be used in minimally invasive glaucoma surgery procedures. So with MIGS, the importance and resurgence of gonioscopy has increased. And before starting any minimally invasive glaucoma surgery procedure, it is mandatory to do a proper gonioscopy in clinic. Know and identify your landmarks and do a proper intraoperative practice. Also, the patient and the surgeon positioning, rotating the patient's head away from the surgeon and microscope towards the surgeon. Then intraoperatively, you start by identifying the landmarks. Again, scleral spur is the most important landmark, which is seen as a bright white line. So the problems with gonioscopy is that it is a subjective procedure and it is uncomfortable for the patient, and also it is a contact procedure. So comes the usefulness of ASOCT and UBM. ASOCT is the advantage is that it is a non-contact procedure. It is objective, and not only it provides a qualitative analysis but also a quantitative analysis for angle parameters. Right now we have the spectral domain ASOCT and recently the SWEPSOS ASOCT, which has a good image depth range around 6 mm. So these are the objective parameters which ASOCT provides, which helps to identify the risk of angle closure. So the CASIA or the SWEPSOS OCT, the recent one in the field, can give 360-degree session and 128 sections with 256 angles can be seen with the CASIA SWEPSOS OCT. This is one of the recent parameters, the ITC index, which helps us to predict the amount of angle closure disease. So this study has shown that the ITC index has an area under the curve of 0.83 and the index had moderate agreement and a good diagnostic performance with gonioscopy as a reference standard. Still, gonioscopy is considered the reference standard. And the disadvantage of ASOCT is that the scleral spur cannot be identified as much as in 30% of the cases, and indentation is not possible. Variability is also high. Next is the ultrasound biomicroscopy, which is very helpful while seeing the angle, especially in cases of hazy cornea. Also, we can see beyond the ciliary body, which helps us to diagnose plateau iris, etc. And it gives good cross-sectional images. The disadvantage of UBM is that it is cumbersome and it requires highly skilled operator to perform the scans. So the newest one in the field is automated gonioscopy. This provides high resolution 360-degree imaging in 5 minutes. and the images can be combined into a single photograph. But the problem is that indentation is not possible and it's an expensive technology. To summarize and conclude, gonioscopy is still an underrated and underutilized examination technique. But with the growing popularity of newer angle procedures and the treatment of glaucoma, the importance has increased multifold. With developments in ASOCT, UBM, and automated gonioscopy, it can be great adjuvants for clinical diagnosis. Thank you. We'll take some questions in the end of the session. So next we have Dr. Sharmila ma'am, who will be presenting on managing cataract and glaucoma in nanophthalmos. She is an expert and her area in interest is nanophthalmos. She'll be speaking on nanophthalmos.
So we all know that nanophthalmos are small eyes, but hence cause huge problems. Cataract or a glaucoma surgery in nanophthalmic eyes is prone for potential complications. One, because of the crowded chambers, the thicker sclera, increased vitreous pressure, and also the risk of associated uveal effusions. And until date, there's no clear consensus on the ideal surgery or the role of sclerostomy in these eyes. In addition to that, there are also several inaccuracies in the calculation of IOL formulae, the scarcity of the high-powered lenses which are available, the lens material to be used, the type of aberrations that is involved with these lenses are all plenty. So let me present a 61-year-old lady who presented from Karaikudi. She had defective vision in both eyes since 2 years of her age. She had small-sized eyeballs. Okay, she had small eyeballs with the use of thick glasses since childhood. She had a similar history in the family with her siblings having the same problem. So on examination, her best corrected visual acuity in both eyes was 636. She had a narrow palpebral aperture with a deep socket, and her anterior chamber was extremely shallow, and she had an immature cataract in the right eye, which was more than the left eye. I'm not able to move my slides. So anterior-segment examination showed a shallow anterior chamber in both the eyes. And then her intraocular pressure by applanation was 34 in the right eye and 16 in the left eye. Gonioscopy showed closed angles with peripheral antisynechiae. The fundus examination, it had a hazy view because of the presence of cataract. However, in the right eye, it was very faintly seen with a hyperopic disc. The ocular biometry was done with an IOL Master 700. The axial length, you can note here, is very critically low. That is 15 in the right eye and 14.86 in the left eye. Anterior chamber depth was 1.7 in the right and 1.6 in the left eye. Lens thickness was 5.4 in both the eyes. The required IOL power for this patient was 57 in the right eye and 58.5 in the left eye. The RCS thickness was 2.09 in the right and 2.01 in the left eye. So these were the B-scan and UBM pictures showing a thicker sclera. So with this, a clinical diagnosis of nanophthalmos with secondary angle closure glaucoma and immature cataract in both eyes was made. The concerns in this case, as was very obvious, was one, a very high intraocular pressure, extremely short axial length, a very high RCS thickness, requirement of a high-powered lens, dense cataract, and extremely shallow anterior chamber. So how do we manage these? So the goals of management should be one, to correct the refractive error, number two, to remove the cataract, number three, to treat the glaucoma, and also to manage the uveal effusion. So first, we went ahead and did a gonioscopy and did a laser PI in view of occludable angles. So this is a routine which we follow. So all patients will undergo a laser peripheral iridotomy 2 weeks before the surgery, and then put them on anti-glaucoma medications depending on the intraocular pressure. So what next? Do we manage the cataract or do we manage the glaucoma? So we all know that any surgery in these eyes are prone for potential complications. The surgical risk could be leading to suprachoroidal hemorrhage, flat chambers, choroidal effusions, cystoid macular edema, corneal decompensation, retinal detachments, and of course, malignant glaucoma. So what are the surgical options? Do we do only a cataract surgery? Do we treat the glaucoma by doing a trabeculectomy? Or do we do a combined cataract and glaucoma surgery? Or do we do a cataract with a window surgery? And another question is, do we do a combined procedure together or we do a stage procedure? So multiple things come into a surgeon's mind as to manage these cases. So first what we did was the right eye pressure was extremely high. Even if the pressure was normal, it is usually difficult to operate in these eyes. So having had this high pressure, we thought we would first do a micropulse, reduce the pressure to a safe level so that it would be easier to do the surgery. So we did a micropulse in the right eye. After micropulse, the pressures dropped 2 weeks later, and then we planned for a phaco with simultaneous prophylactic sclerostomy, right followed by the left eye. So preoperative planning is something which is very, very important in these eyes. The course of steroids is essential because it might reduce the effusions if it was present earlier. Intravenous mannitol infusion is mandatory for all these patients at least half hour before the surgery. It will shrink the vitreous pressure and thereby it reduces complications intraoperatively. We prefer to use a subtenon anesthesia and always ensure that there is availability of retinal surgeon to perform the sclerostomy. So this is a video of this patient who had a near mature cataract. An inferior sclerostomy was done. Usually we prefer to do it in the infratemporal quadrant, 10 to 12 millimeter away from the limbus, as close to the vortex veins as possible. You can see a superficial scleral flap of 4x4 measurement, rectangular shape is being raised, below which a 2x2 millimeter, a deeper scleral flap is raised, and this flap is excised, exposing the underlying choroid. So here this is created like a window, and the edges of which is cauterized so that it remains patent, and the superficial scleral flap is reposited back. So following this, there is a softening of the eye as seen here. So this gives immense relief for the surgeons to perform the rest of the cataract surgery very smoothly. I generally prefer to use a trypan blue to stain the capsule, and the routine capsulorhexis, hydro, and stop and chop technique is used to complete the procedure. So very comfortably I could finish the surgery. One important thing is these lenses are very thicker, so it is important to extend the wound. You can't do it with a routine 2.2 millimeter incision. Extend it to 3.2 and then place the lens. So once that is done, close the wound and then close the conjunctiva also. Post-operatively, you can see on day 1, the eye which had 15 axial length, you can see how clear it is. Anterior chamber is deep, lens is well placed. So the post-op difference, pre and post-op difference in anterior chamber depth is appreciated here with a deepening of the anterior chamber and decrease in the choroidal thickness. So the follow-up visit, the vision was 6/36, pressures were 14, and patient was on antibiotic and steroids. So the merits of performing a prophylactic sclerostomy, we all know the pathology is because of a thicker sclera or the vortex vein compression, which leads to retinal pigment epithelial dysfunction causing SRF accumulation. So a randomized study which we did clearly proved that performing a sclerostomy minimized the risk of complication compared to those eyes who did not undergo sclerostomy. And the risk factors were more in patients who did not undergo sclerostomy and patients who underwent a small incision surgery rather than a phaco, and those who had a high intraocular pressure preoperatively and very high lens thickness. Subsequently, we did a larger analysis of patients with clinical spectrum of nanophthalmos, and here we found that patients who had a peripheral anterior synic A, they had 3.6 times higher odds of going into angle closure glaucoma. And many of these patients who underwent surgery ended up with complications. So it is important to understand that complications are inevitable in patients undergoing a surgery. Surgery should be considered as the last resort and preferably use a stage procedure rather than a combined surgery. And same was reported even in the literature. So the tips of doing a safe surgery would be in trabeculectomy, you do a pre-placed sutures, tight closure of the scleral flap, and better to avoid a combined procedure and go for a stage procedure. And maybe you can reduce the intraocular pressure preoperatively by either a transscleral diode or a diode cyclophotocoagulation. So the take-home message here are, nanophthalmos is a rare entity with a high risk of angle closure glaucoma and uveal effusions. It is important to individualize the treatment options based on the axial length, RCS, IOP, GONU, and fundus findings. Surgery should definitely be the last resort, and it is better to go for a stage procedure. A timely diagnosis and prophylactic sclerostomy is a must to avoid uveal effusions. Most importantly, a good counseling is necessary because most of these patients do not have good visual outcomes because of underlying amblyopia and foveal hyperplasia. Thank you for patient hearing, and I thank Madhavi for the opportunity. Thank you.
Thank you, ma'am, for a wonderful presentation. Next, we have Dr. Devendra Maheshwari. Sir will be talking on one of the greatest conundrums, whether we should go for laser iridotomy or lens extraction. What is the current trend in PACD management? Over to you, sir.
Yes. So good morning, everyone. Thank you, Scientific Committee, for giving this opportunity, and thank you, Madhavi, to inviting me in your IC course. So today I'm talking about the laser peripheral iodotomy and lens extraction in primary angle closure disease. So it is a controversial topic. Some people used to perform still like to do the LPI instead, and the recent trend is coming. People are doing the cataract extraction instead of the LPI. So somehow there's a little bit controversial topic. It depend upon the what you want, and we have just searched for the few literature. So what the literature suggested and what should be the current practice. Why it is important? Because we see the incidence of primary angle closure disease is going to be huge. If you see that by 2040 we will have the 21 million PACS case, and followed by the 4 million PAC, and 2.4 million will be the PACG. So we have the large chunk of the population of PACS in the future. So either what we are going to do in such cases, either we are going to observe or going to the LPI. So these are the various multifactorial disease, primary angle closure, having some genetic, anatomical, and some environmental factors play a role to developing the glaucoma. These are the various mechanisms of angle closure, including plateau iris, pupillary block, phacomarpic, aqueous misdirection, and the mixed mechanism of the glaucoma. So we know how the disease progress, really how primary angle closure, natural course of the primary angle closure really is, we don't know. But actually the study done by the Thomas et al. Has showed the PACS convert to the 22% PACs convert to PAC at the end of 5 years, and out of nearly 30% PAC convert to the PACG. So these are the various treatment options available for at present for the primary angle closure disease, as discussed by my previous speaker. So I will just talk about that LPI and the cataract extraction. So as all we know that by doing the LPI, why we are only dealing with the only single mechanism. What we are doing, the pupillary block. Pupillary block is the most common mechanism of IOP elevation in PAC and PACG. By doing the IOC-PI, just we are relieving the pupillary block, widen the angles, and reduce the pressure difference between the posterior chamber and anterior chamber. But even after doing the IOC-PI, certain angles don't open and IP didn't come out because the part of the angle closure is not due to the pupillary block. There is certain other mechanism involved, like the much more narrow angles, more anterior iris insertion, thicker iris, plateau iris, and the large lens. So by doing the IOC-PI, we are dealing with the one part of pathology of the angle closure. So we have to think, why are we doing the more LPI? Is justified or not? And how we should manage the asymptomatic PACS. So these are the various studies has been done. They said, they concluded the primary angle closure suspect, only the few cases we reached to the acute endpoint or develop the acute angle closure glaucoma. So these are the studies, I think, well covered by Dr. Indra. Singapore asymptomatic narrow angles iodotomy study, analysis study. In this study, they did in the patient, they recruited the 476 patient, one eye underwent iodotomy, second eye for the observation. And the endpoint was either elevation of the IOP or developing the acute attack. And what we learned, without intervention, 10% of the PACS progressed to the angle closure versus the 5.3% in the LPI group. So even after doing the LPI, certain patients developed to the angle closure glaucoma. So that another trial is called the JEP trial. This is also compare its outcome, compare the intervention LPI in the one group, either the observation in the other eye. And what we find out, the rate of developing any angle closure without watch much lower, expected the primary angle suspect less than 1% of the year. So what we learned, even after doing the IOC-PI, we are not preventing the angle closure glaucoma in all the cases. So therefore, despite the IOC-PI is not recommended to the general population or into all the PACS patient. But we have to keep in mind, JEP trial has some issue. Most of the patients are Chinese and the younger population are recruited from the community. So they had the argument in favor of the LPI. Why we should do IOC-PI? Because acute angle closure is a potential blinding disease and no harm in doing the LPI. Because LPI is a non-invasive procedure, can be performed in the OP settings. So argument against the LPI, because LPI is not totally blind, you may have IOP spike, iritis, and can accelerate the cataract progression. So what we should do? So World Glaucoma Association do the consensus for the PSCS, which PSCS should go for the LPI. The patient who having the fellow eye, having the PSC or primary angle closure or acute attack, symptomatic PSCS, patient who need the regular dilatation, like having some retinal pathology or poor access to the healthcare system. They coming from the rural part, coming to one time, coming to the hospital, they're not coming to you again. I think this is a nice, good opportunity to go for the LPI in such cases, and the family history of the angle closure disease. And recently we saw in the either we remove the cataract, either clear or cataractless lens, we removed it. Definitely IP is going to come down and improve the outflow facilities. So the various studies has done and showed it after doing the cataract surgery in compared to the traditional treatment like trabeculectomy or LPI, IP is going to come down and almost equal to the other interventions. So this largest trial has been, worldwide trial has been done. It's called the EAGLE trial, in which they compare the phacoemulsification IOL implantation versus LPI in the PSC and the PSCG cases. So what this trial recommended, the clear lens extraction was superior than standard care in terms of the patient-reported healthcare, IP control, and need of the anti-glaucoma medication. But these results indicate clear lens extraction should be considered the initial treatment for PSC and PSCG with increased IOP. However, we should keep in mind when we're doing the clear lens extraction, it's a trend toward the clear lens extraction, but keep in mind, discuss with the patient all the options, because still in India, we feel there's no need to trend for the clear lens extraction. And they have some issues, like they have the not true lenses. The most cases are mild cases, and EAGLE trial mostly dealt by the experienced surgeons. Coming to the argument in favor of the lens extraction is provide good IP control, cost effective, improve the patient's quality of life, better safety profile, and need the less anti-glaucoma medication. But why we should not go for the lens extraction, especially in developing country or country like India, because the complication of the surgery and the intraoperative complication surgery, especially in India, when we don't have the enough manpower of the qualified surgeon, even if the experienced surgeon can have the complications, especially in the PSCG and angle closure disease. And in developing countries, definitely we have the cost is the major concern. We can easily do the AIOL instead of going for the clear lens extraction case and the risk of infection. So just to summarize, medical management LPI remains the most common mode of the treatment. The decision to be clear lens extraction must be individualized, weighing the risk and benefit and complication of the intraocular surgery. So we should understand the PSCG, primary angle closure disease, is not a single disease, it's a multifactorial and it's a multiple stages of the disease. So each patient can be unique in terms of disease stage, and the management should be tailored according to the stage of the disease. Thank you, Professor.
Thank you, sir, for a great and elaborate presentation and giving us pros and cons of each in detail. Next, we have Dr. Moideen Abdul Qadir, Chief of Glaucoma Services at Aravind Eye Hospital, Tirunelveli. Sir will be talking about cataract surgery in angle closure disease. We all know which is very difficult to do a cataract surgery, and he will be talking on how to traverse the limited space.
So the tough case to do a cataract surgery in angle closure glaucoma. Just give a small example. A 67 years old female patient, 1/8 patient, came with acute attack in right eye. Axle is 21.47, lens thickness 3.61, and IOP is 46 and 0.1 cup. Other is 56 and GOA. And she had undergone a trabeculectomy for this disease, and after that she had a shallow chamber in day 1, pressure is 19, and it was. Around the day 15 is 50, and we all just managed with medical management, and we just waited for 4 months, and the vision dropped because of cataract. And so the post-trap AC shallow, speed grading is 2 to 3, and CL negative, and clear lens, and vision 160. Pressure now 10 with 2 anti-glaucoma medications, and the loading dose of topical steroids and atropine. We are suspecting a malignant glaucoma along with cataract. So what do you want to do? We had a vitreous surgeon standby for vitrectomy, and this is a video just to show. We just put 2.8. We put a Triptan blue, and we stain the anterior capsule. we release all the pus. We form the anterior chamber. We remove this people stuck from the ostium. Then we use multiple side port. So you can see that pupillary membrane is one of the culprit which is not allowing the AC to form. So we just swept all the peripheral synechiae from the pus. Then we found out the pupillary membrane. So we just remove the pupillary membrane. It's like a capsular rhexis called pupillorhexis. So we just remove the rhexis fossa, do a 360-degree, remove the pupil. So once you remove the pupil, you are more or less, you are, sometimes we think of the anterior capsule, so we have to be careful. So you don't puncture the anterior capsule. So once you remove this pupillary membrane, and then you get a clear idea about the anterior chamber. So once you get the, so if you do a 360-degree pupillary membrane removal, then it'll be very easy. Then you can see, then you form the AC with high viscosity viscoelastic. Then you use a hydrosoak. So no, don't hesitate to use hydrosoak. So use a hydrosoak. So normally we make 4, but here sometimes we can make even 5 also to make the pupil a little bigger. So once you form the AC, once you remove all the peripheral synechiae, then you remove the pupillary membrane, then more or less much easier. And see to that you give intraoperative mannitol also be given at least a 200 ml on the block room, on the on table. So you make the eye a little softer. Then you do again you use of forceps, because this has a weak zonules, and this most of the lens will be anterior subluxated. So you have to be careful. So you cannot use a cystitome to complete your rhexis. So use you go back and retake that rhexis margin and complete your 360 rhexis. Then once you lose the rhexis, then you can't do a phaco, especially in these cases. So everything has to be precise, and you have to plan very well before the surgery. So as the experienced surgeon, it's better to do this kind of cases, because sometimes very difficult to manage, especially intraoperatively. And once you do a general hydrodissection, don't do multiple, just a general dissection. And again, you decompress the anterior chamber, decompress your back. Then you just use a routine stop and chop on whatever it is, chop on. Only thing is you take the multiple pieces of the nucleus of recommendation, because if you do multiple pieces, the less chances of causing damage to endothelium. You do only 2, 3, and you try to eat because the chamber is very narrow. So it's better to make to multiple to 8 to 10 pieces of this nucleus. Then you can emulsify, and the parameter setting is low parameter. See, my vacuum is only around 1, it doesn't go more than 200. So leave the low parameter vacuum, lower aspiration rate. Then you finish your phaco. One more thing is, once you finish the phaco, the subincisional cortex is sometimes difficult to take it out. So don't hesitate to use bimanual IA to remove your, especially your subincisional cortex. So because that will be very easy, otherwise you'll be struggling to do. And also, next thing is better to use a 3-piece in the intraocular lenses, because the 3-piece have better stability of your lenses. Because use a single piece, then the whole lens will be pushed anteriorly, then you will not be able to form the AC. So better to use a 3-piece. So you can also do either sulcus, or you can use a fixation in the back. So once you dial into the back, then you are more or less safe. And one more thing, you try to remove the visco under the IOL. Normally we don't remove under the IOL, better to remove under the IOL. See, the rhexis margin is vertically oval. It typically shows. At the end of the surgery, also try to close the wound. Again, very important to close the wound at the end of the surgery. So this is the pre-op and post-op. AC is formed, and a little bit of FM is there. And the intraocular pressure 1 month is around 16, and the vision is improved to 6-12 of this case. This is again an intraocular malignant glaucoma, because this is a surgery done by one of my fellow, and then they called me for high pressure. And then I just went there, I removed this, I put the nucleus back to the patellar fossa, because he done a multiple hydrodissection, the nucleus is pushed forward. So because of that, I told to shift case to my table, we just waited for give mannitol, then he proceeded with a phaco, the slow setting. This way, this is if we do multiple hydrodissection, especially in a narrow angle, you can have an intraocular malignant glaucoma. I have to be careful. Then you do a slow setting, then do multiple pieces of again phaco emulsification. Then you can safely finish the cases. Again, use at the end of the surgery, better to. You saw the initial stages that the iris was floppy, and when I push, always better to feel the eye whenever you're doing phaco, because sometimes it will be very hard, then you cannot proceed. The eye is softer, then you can proceed. Okay, again use a bimanual to remove your subincisional cortex. Then at the end of the surgery, you need better to suture the wound. This kind of cases need to suture the wound. If you don't suture, the high chances of see the floppy of the iris. It's better to suture the wound so that you don't have any post-op complication. So I think the challenge is, especially in this case, the shallow anterior chamber, decreased endothelial cell count, thick lens, poor dilatation, floppy iris, posterior sinus, high IOP, weak zonules. These are multiple component, and I think it is breaking the sinus using high viscosity agents, and intracameral adrenaline also can be used. Sometimes be careful to use adrenaline because of endothelial cell count can come down with this also preservative of adrenaline. So better to aspirate the lower rate and lower vacuum and use a better viscoelastic, and better to remove this viscoelastic under the IOL just before you come out. And intraocular pressure IOP is common, especially in the complication, and DM detachment is also common. Into the cell loss is also 5%, and we may need for PKP. So 7 points I say is do a pre-op assessment, especially give diamonds of oral cell pre-op. Intra-op assessment is very important. Feel the eye. That's very important. My boss has taught me. Whenever somebody has a difficulty, feel the eye. If the eye is soft, you proceed. If the eye is hard, close the eye, do next day. So intraoperative mannitol is important, and forming the anterior chamber, especially pars release, pupillary membrane removal, and use of high viscosity sodium hyaluronate, pupil dilator, endothelial protection with visco, slow phaco, remove visco from under the IOL and suture the wound at the end of the surgery is very important. Thank you.
Thank you, sir, for sharing those videos and giving us wonderful pointers. If doing phaco in angle closure disease is difficult, phaco trab is yet another ball game. So we have Dr. R. Ramakrishnan, my chief and my mentor, for talking about the phaco trabeculectomy in angle closure disease. Let's hear us from the stalwart, Professor Dr. Ramakrishnan, sir. For want of time, we'll take questions in the end if possible. So we'll go on to the next talk.
Good morning, everybody. At the outset, I would like to thank AIOS and the local organizing committee for wonderful arrangement. And also I have to thank MADHAVI for giving the opportunity. And of course, management of glaucoma itself is a very challenging problem in the field of ophthalmology. That too, management of angle closure glaucoma is much more challenging. That we have seen in the previous speaker by Mohideen, Devendra, Indra, Sharmila. All are very, very difficult situations. And of course, the glaucoma is not normal eye. Any type of glaucoma, it's open angle or angle closure, it's a sick eye. It's not coming. Shall we put it here? No. Yeah. Okay, thank you. Okay, yeah. So it's a sick eye. It's angle closure glaucoma. When compared to open glaucoma, it's different in so many ways. So number one, is very small when compared to, because accident is very, very short, and chamber is very shallow, and the angle is very close, and the thick sclera and choroid, which leads to a lot of other post-operative complications like suprachoroidal hemorrhage or ovial effusion. And most of the times the people will be very small, mid-dilated people. It's very, very difficult to work in a mid-dilated people in a very crowded anterior chamber. And also intraocular pressure most of the time to be very high, and also prone to many complications. So now the important thing in managing glaucoma, any form of glaucoma, especially angle closure glaucoma, we are not afford to make any complications during surgery, because it will completely affect the outcome of the surgery, because post-operatively patient can go for so many untoward incidents like what Mohideen has pointed out in his talk. And also relative pupil block, one of the important, because when you diagnose angle closure glaucoma, because there are so many other varieties. So primary angle closure glaucoma, it's most of the time it's with the pupillary, it's commonly with the relative pupillary block. And without a relative pupillary block, you see your plateau iris syndrome. That also, because about 25 to 30% of the angle closure glaucoma, what we normally see in our day-to-day practice, tend to be, unless we do a thorough investigation, will we see plateau iris syndrome or configuration. And laser radiotomy, as pointed out by Devendra, so the important treatment modality for angle closure glaucoma, it has got, because surgery is not that easy in angle closure glaucoma. So mainly it's in the early stages laser radiotomy, and in some other cases where IOP is not controlled, medical management is very, very essential. And of course, if it is not controlled, depending upon the lens situation and the level of intraocular pressure, either we can go for a trabeculectomy alone, or the intraocular pressure is very high and not controlled with medication, with operable cataract, we can go for a combined surgery. Then factors other than IOP, as I already mentioned, plateau iris configuration, and also the changes in the lens thickness and its position. And iris volume also plays a major role. So one of the study done by Quigley found out that the choroidal thick expansion and iris volume and thickness also plays a major role in the angle closure glaucoma. And lens thickness and position, age-related growth of lens, and especially nuclear sclerosis and changes in lens position due to zonal laxity, and of course role of lens already dealt by our Devendra. And coming to the management, because all of you know very well, glaucoma management, 3 modalities, medical, laser and surgical. And of course, laser has got a wonderful place in the management of angle closure glaucoma. Of course, medical management in the early stages with moderate intraocular pressure with the clear lens, it has got a very good result. It can be 1 or 2 medication, but especially in places like countries like us, where the patient cannot afford to use more than 2 or 3 medications continuously for lifelong, is very, very difficult because of the cost. And also another important aspect is the poor compliance of the patient. Whatever may be the economical background of the patient, the compliance is very, very poor in due course of time. And also not only that, even a good compliant patient, rich patient, suppose they have the effect on the drug, then it's very, very difficult to control the intraocular pressure. Then of course laser radiotomy, the efficacy is one thing we have to, it's not uniform in all the patients, not all the, depends on the stages of the disease. And also need for medications definitely needed. And is cataract surgery alone is enough? Because there are so many studies have been done, and usually they will temporarily reduce intraocular pressure. And although it seems to have no effect on regional IOP, but the intraocular pressure reduction after cataract surgery alone is transient, temporary, and it will, most of the studies show that it will last for about 1 or 2 years. After that, it will come to the baseline. And so, and also the intraocular pressure reduction also depends upon the it's not hard and fast rule. It depends upon the stage of the disease, and also the thickness of the lens and amount of angle closure ranges from 2 to 12 millimeter of mercury. And of course, trabeculectomy has advantages over phacoemulsification for the treatment of primary angle closure glaucoma in terms of better IOP reduction, and also the reduced number of medication post-operatively to control the intraocular pressure. But one of the important things we have to keep it in mind is the complications. The complications are very, very high if you do a combined phacotrabeculectomy when compared to simple cataract extraction alone, because of the you can have a shallow chamber or choroidal detachment or malignant glaucoma, because malignant glaucoma is one of the important things we have to keep it in mind in angle when you manage the angle closure glaucoma. And of course, when we have to do phacotrabeculectomy, because the hypo, as already mentioned, it's the ocular hypertension effect of simple cataract excision is very, very short, lasts for short time, and reaches baseline within 1 year or 2 years. But in cases with refractory glaucoma, that means so if the intraocular pressure is not controlled with 2 or 3 medications, with a patent iridotomy and a progressive visual field loss and visually significant cataract, then there is no other option. We have to combine with cataract excision with some of the anti-glaucoma procedure, mainly because the golden procedure is the trabeculectomy. So, what are the indications? I already mentioned failure of medical therapy and intolerance to medication. Suppose they are not able to tolerate the medical antihypertensive agents, and advanced disease, and also the disease is progressing, then we have to go for phacotrabeculectomy. It's the same thing. Is combined phaco has got a better IOP control when compared to cataract extraction alone. But what are the results? It's not a simple journey in doing phacotrabeculectomy in cases with angle closure glaucoma. So, of course, it is not the advantage of a single procedure per patient is more convenient, and also reduce the cost, the in outcome for frequent surgery, and avoid potential IOP spike following the cataract surgery. And of course, in most of the cases, you can have a long-term intraocular pressure control. But again, it's on the other hand, it has got some of the disadvantage, like the challenging is to perform. That's what we have seen in the previous speaker. They presented how it is very difficult, and also some more prone to have a more intraoperative and post-operative complications, and a long surgical time. You have to be very, very patient. Like Moidin Lord has shown one of the case of post-acute attack, how we remove the lens. You have to be very, very patient. Then otherwise we will end up in a problem. And also long time for visual. It will take a long time for the visual occurring. And also it's before going for cataract surgery, we have to prepare the patient to be a thorough preoperative evaluation, a slit-lamp examination, gonioscopy, and even intraocular pressure, all these things. And also location of the PA. Suppose if a PA is about 9 or 3 or 10, but advice is not to enter the chamber at that area, otherwise iris will prolapse over the. And also assess the number of anti-glaucoma medications. Two things. One is we used to stop all the anti-glaucoma medication at least 5 to 7 days prior to the combined surgery. This is mainly to keep the eye quiet, because following anti-glaucoma medications, there are so much of changes happening in the eye. That's conjunctival, that the goblet cell will come down and increase the population of the fibroblasts, and chance of scarring of the future bulb is very, very high. So we normally used to stop anti-glaucoma medications and to give some weak steroids for about 1 week, so that you can have a better blood formation after surgery. And second important thing, especially in angle closure, in a simple cataract surgery, we want to stop blood thinners like clopidogrel or aspirin. But in cases with combined surgery, it's always to stop this blood thinners, so that you can avoid uninterrupted bleeding during surgery. And of course, the assess the pupillary dilatation is very, very important, because most of the people will be very small, and you have to use the pupil expanders or iris hook to dilate the pupil and look for phacodonesis. And in some cases, we may need this CT, capsular tension ring. And and already, as you mentioned, you have to reduce intraocular pressure to the maximum. You have to give intravenous mannitol, Diamox, or Volgulsa, because you have to have a soft eye during surgery. Suppose if you have a hard eye, the intraocular pressure is very high, then it's very, very difficult to proceed with the surgery. And intraoperative, you can use intraoperative agents to dilate the pupil, and also adequate viscoelastic. Do not overfill the antechamber, then again you will have a problem. And of course, iris hook and to turn blue to this one. And always I prefer to do a twin site phacotrabeculectomy in angle closure glaucoma, because single site, especially superior, is very, very difficult, because you want to have a much work. You will not be convenient and not comfortable in doing single site in the superior. So you just do a phaco in the temporal side and do the trabeculectomy in the superior, so that the manipulation will be very minimal and you will have a better blood formation post-operatively. And also this all the complications. Also, of course, because of want of time, I'm not able to show the video. I will skip that video. And the post-operative management, as usual, we have to give steroids for much more time because of the increased post-operative inflammation along with the cycloplegics. Otherwise, all other management like laser suture lysis or digital massage are almost equal to same as of other phaco triple. So to conclude, always rule out pupil block in any case of angle closure glaucoma, and rule out prior to iris, and consider lens removal or combined surgery in any case of angle closure glaucoma with a significant cataract. And of course, is beneficial for good and long-term intraocular pressure control. And you have to have adequate precaution and preparation preoperatively, intraoperatively, and postoperatively, so that you can have a very good outcome following surgery. Thank you very much.
Thank you, sir, for a wonderful presentation. For want of time, we'll be moving on to the last speaker, Dr. Ravindra, sir. He will be talking on the how to solve acute angle closure crisis, the ultimate deadlock.
Thank you. I'll try to quickly move on through the slides. So the history questions related to angle closure glaucoma are the number of days the symptoms are there, whether the age is more than 50 years, then what are the other risk factors, and then in the anterior chamber we have to see the inflammation, the conjunctiva, we have to see the circumcorneal congestion, corneal edema, we have to see IOP, we have to check, and then we have to look for the iris and the lenticular changes and pupils, whether they are mid dilated, and of course vision is most important. And then these are all the medications that we have to keep in mind, which are the medicines to be used, is to be kept in mind, is to be contemplated. The classical flow chart comes, the initial treatment. Okay. The initial treatment. So initially we have to decide what is to be the what is the diagnosis, whether it is classical angle closure glaucoma or whether it is one of the differential diagnosis. And then the initiation of the treatment is important. We have to give the pilocarpine, oral glycerol or Diamox, and then whether the pilocarpine is to be given in what frequency, means initially whether to give it in quick succession or whether to wait for IOP to be reduced is an important decision, because over 40 IOP, the pilocarpine itself may be harmful. And then once we come to the differential diagnosis, we have to be sure whether it is primary angle closure glaucoma or anterior segment uveitis and cluster or migraine headache or conjunctivitis or giant cell arteritis, glaucomatous cyclotic crisis or IC syndrome or keratitis or neovascular glaucoma, and then whether any of these drugs are the reason for the angle closure glaucoma, it is also important. Whenever it is bilateral angle closure glaucoma, we have to be very careful that we diagnose the exact cause and withdrawal of the treatment that the patient is having, and the precipitating cause may be the main mode of treatment. And if it is uveitis, we have to give the steroids. If it is lens-induced glaucoma, we have to go for the lens extraction. Whatever it is, whenever it is angle closure glaucoma, early intervention is the key, and triaging of the patient upon reaching the hospital is one of the most important things. Otherwise, the long-term effects upon the neuroretinal rim and angle and nerve fiber layer will be apparent. And one of the most important things is gonioscopy, so that we do not miss the prevention aspect of the acute angle closure glaucomas. And after the PI has been done, it is important to identify plateau iris so that we identify the reasons and treat in the correct modality. And if it is not the primary angle closure glaucoma and silicone oil glaucoma, we could be in for unpleasant situations, and therefore appropriate treatment, laser medical treatment will be required. And if the trabeculectomy is risky because of in uncontrolled IOP, we may have to do IV mannitol, and then still IOP may be not lowering, and then cyclophotocoagulation has got a place there. And so laser iridoplasty was also discussed, and compared to PI, it is not so efficient, and for the termination of the acute attack, it is somewhat useful. And so I have been able to quickly move ahead and give the hall to the next speakers. Thank you.
Thank you, AOS, for giving us this wonderful opportunity. And I thank all the co-instructors who participated in the Young Master IC. For want of time and the next session to start, we'll leave the podium as early as possible. Thank you.